today, Ian Wright, who is speaking to us from Tuscany at the moment, which is wonderful. And we were just chatting recently about Ian's books, which he's written around one on anxiety, or healing anxiety, another one on the dynamics of stillness, and another one coming up about the practitioner's journey to wholeness, which I'd love to see that. So those of you who don't know Ian, he's been practicing cranial and particularly pediatric osteopathy for well over 30 years now and lectures internationally all over the world. And he has a lot of experience about the subject he's going to be talking about today, which is around concussion. So Ian's going to speak for a while and then we'll open up for questions. So please come forward with those and just put them in the chat. That'd be wonderful. So welcome, Ian. Thank you for being here. It's lovely to see you.
Good to be here.
Great.
Stop me if I go on for too long.
Oh, that's fine. We've got about an hour, so.
Okay, well, should
Cool.
be able to cover it, hopefully, in that.
Wonderful.
So, yes, it's an interesting, I suppose, as an introduction to it, it's a particularly interesting area of work. And here I'm going to talk about practitioners of craniosacral therapy and cranial osteopathy, okay? Because there's obviously enough similarities in those two in terms of their potential to have effect. And I'm not going to go into which blend of cranial osteopathy and which blend of craniosacral therapy. It doesn't matter because I've taught all of them and I've experienced in all of that side of things. So that's to start with. The reason why I suppose it's so important is that there really aren't that many tools that people have for managing concussion or post-concussion syndrome. There's four different things here. There's concussion, there's post-concussion syndrome, which is a mild form of traumatic brain injury. And then we have the idea of chronic traumatic encephalopathy, right? Which is, I'll talk about each of those in turn and how they all interconnect and where we can get to it. So concussion, the first term, this was first mentioned, these kind of terms, a long time ago. This has been in medicine a long time ago, in fact, for almost 1,000 years. And it comes from the Latin word concussus, which is the perfect tense of concutio, meaning to shake violently, okay? Now it's classified as a mild traumatic brain injury. But the thing with it is that it doesn't show any damage on a normal CT scan. So it's a traumatic brain injury where you can't actually see evidence of it. So post-concussion syndrome, which is now termed long concussion after the whole long COVID thing, is when symptoms of mild concussion persist longer than expected, and they can accumulate it with repeated head trauma. The accumulation is a really important thing, which we'll talk about. So what are the symptoms of acute concussion? Okay, normally, and they can be other things, there's a headache, a sense of pressure in the head. You can have nausea and vomiting. You can have sound and or light sensitivity. You can feel sluggish and groggy. You can get a bit of brain fog. You can feel a bit emotionally low or anxious, okay? Or you can get more severe effects, like, for example, a seizure, okay? So most of these concussion symptoms will resolve over 7 to 14 days. Okay, that's really important. So persistent post-concussive symptoms are symptoms that last over 2 weeks, over 14 days. And they can include headaches, a sense of irritability, a sense of anxiety, sleep issues, meaning you can't get to sleep or that you're always feeling sleepy, a loss of concentration, memory, ringing in the ears, blurry vision. You can have noise and or light sensitivity. And in certain cases, which I'll talk about, you can get a sense of loss in smell and taste. Quite commonly, feelings of depression, and you can have gastric and occasionally cardiac symptoms, heart symptoms, which we'll talk about later with regards to the vagal nerve. Now, a word about children, because I do kind of specialize in pediatrics. Often children, you don't know they've hit their head because you can't watch them all day. And especially young toddler children, if they take a fall, they're crying. You don't know why they're crying. They can't effectively communicate it. So you don't know necessarily if they've actually banged their heads. What you need to see, which is when I was thinking about this, it's a pretty obvious thing actually, but if a child is vomiting, if they're listless, if they not showing clear consciousness or they can't stand properly, and if they're vomiting, that's a sign to take them to hospital. But actually, that's a sign to take a child to hospital anyway. That's a kind of red flag anyways. So you don't know what it's from. It's interesting that more women than men suffer the effects of concussion and post-concussion syndrome, which is kind of interesting because probably more men get head injuries. So there is one hypothesis which is going around about it, which is if a woman receives a head blow in the last 2 weeks of their cycle, it can affect the HPO, the hypothalamic pituitary ovarian function, leading to less progesterone production in the ovaries, adrenals, which can create an increased sense of withdrawal in them. And that could accentuate sensations of pain and nausea and dizziness, which may be interesting. I'll talk about that later. So how is concussion diagnosed? Okay, so you've got these assessment tools, head injury assessment tools. This is the one that is used by World Rugby, actually. And they go through, it's quite interesting. You go through a series of questions and you rate this person, and then you'll be able to tell. And I'm going to go through them because it's actually on some of them, they're quite interesting. So that you ask the person who's received a head trauma, what venue are we at today? Which half are you in? Say they're playing a match. Who scored last? What team did you play last week? These are always things. When did a team last win? If they can remember that. Then you have to test your memory. So they give you some options like, so the person assessing them, and they don't need to be a doctor, can say elbow, apple, carpet, saddle, bubble, say. Or there's a various options. And you have to remember that and say it back to them, okay? And then sequences of numbers, okay? And then there are certain things. You can watch them standing to see if their balance is normal, and you can provoke that to see if they can hold a gait with 2 legs. And then you ask them for the usual symptoms: headache, dizziness, pressure in the head, nauseated, blurred vision, light or sound. Do you feel as like you're slowing down? Do you feel like you're in a fog? Do you feel unwell? Okay. Any emotional symptoms? And so then you get graded. And if they have a certain grade of things, bang, you'll be taken off, whatever. So that's how it's done. Now that is overridden if there is a doctor there who will do a neurological screen, say simple kind of pupil response reflexes, et cetera, et cetera. So that medical evaluation is important part of it. So concussion involves multifaceted neurological, mental status, vision, gait, balance, sleep-wake cycles. Evaluation, if you have some sort of traumatic brain injury, is MRI, CT scans. Okay, but it's not. The point about this is it's not completely reliable as a tool, but even if you take MRIs and CTs, because a lot of the kind of pathophysiology of it is unseen at that level, and it's more on a cellular level. So, but also a very big issue is you can have an absolutely normal CT, MRI. You can have no symptomology at all. So the brain seems like it's fine, and they've taken their 2 weeks off. say. I think it's normally about 2 weeks for a jockey. It's about that kind of time if you've had an injury, 7 days, 14 days after the last symptom. It depends. But these measures don't reflect the process of physiological brain restoration, right? And so it's widely considered by researchers, and certainly by me, that the brain is slower to recover than the symptoms show. Okay, and recent studies with neuroimaging reflect this as clearly the case. So there are some, like the pathophysiology of it, is there are some changes when you've had trauma to the head. I'll talk about the types of traumas as well in a minute. But you can have direct changes in the glucose metabolism in the neurons. You can get very small vascular damage around in the areas that are certainly around the cortex, and you can have inflammatory changes. What happens when there's a big jolt at a cellular level? Potassium flows out of the neuron and calcium and sodium flow in, which creates a widespread neuronal depression, and it affects the mitochondria, which are the kind of powerhouses in the neuron. So you get these large or small areas of micro damage. You also get poor cerebrospinal fluid fluctuation, of which we'll talk about a lot later. So what happens on a micro level, and they're just starting to see this, is the neuronal microarchitecture, which is the connective tissue within the cells, which is thought to be very important in neuronal communication, because there are these, I'm going to go a bit off track here, but basically the brain is seeming in some of the modern field theories of brain function, and I teach courses on neurodiversity where I go into this quite a lot, that it's not just synaptic exchange, neuronal function, that it's too slow. The brain works much quicker than that. And so some of these modern theories of field function and even quantum field function make more sense as different modes of brain function. And so a lot of that is engaged with some of the connective tissue function. Okay, so the microarchitecture within the neurons is seemingly very important. So this is important also in children who've had traumatic brain injury. Okay, so because some of the long tracks, certainly in the first year, are not myelinated, haven't got their covering, they're less protected. So actually head injury in a young child could actually lead to more damage than we want, okay? So there are 3 types commonly known, actually, of concussion we're talking about here, okay? There is direct impact, so you hit something directly, you bash it, bang, okay? That's direct impact. The actual direct physical force is it directly affects the brain, okay? The brain is well protected for this, which I'll talk about in a minute. You have acceleration, deceleration brain injury. So the brain gets shifted in the container, okay? So that's actually the problem, is the movement, the jolt, right? And the jolt can be, say, for the classic maybe is from a road traffic accident, where you put your hands on the steering wheel and the seatbelt and your head is thrown forwards and backwards. So there's a very rapid acceleration, deceleration. You're not hitting the head directly, but it's the movement of the brain, which is quite heavy inside, that causes a lot of micro damage, okay? But that can also be being hit by a rugby tackle, okay, or a fall. And the fall can be quite commonly, the fall can be on your butt, on your sacrum, okay? And that creates a very precise and particular pattern in as well as a certain type of conscious concussion. So the final type is a blast injury, which is if you're near an explosion, right? And this can cause multiple diffuse brain pathologies. Now, that isn't just a blast, because I was treating this guy in hospital who actually had these multifocal diffuse brain pathologies, and he had been in a very severe road traffic accident, and where the person with him lost their life, and he was in a coma when we started. Anyway, that's an interesting one. We'll come back to that maybe. So there are three grades of concussion. Okay, grade one, no loss of consciousness, right? No loss of memory, or loss of memory for less than 30 minutes. Okay, grade two is a loss of consciousness for less than 5 minutes, and amnesia for 30 minutes to 24 hours. Okay. So now the grade three is a loss of consciousness for more than 5 minutes, or amnesia or amnesia for more than 24 hours. Okay. So the classic medical intervention in this. So it's mainly screening. Yeah, especially if they've had a loss of consciousness, they want to screen and see if anything comes up, especially things like shaking, seizures, repeated vomiting, especially, as I said, in children. They'll give paracetamol for pain types, because you don't use non-steroidal anti-inflammatories, because that could potentially cause a bleed to the site of the injury, which is kind of an important thing to remember. Sleep is the biggest healer, because it's vital, because the brain has a chance to detoxify and heal, and has certain movements of the cerebrospinal fluid in sleep, which we'll talk about if we have time later, which helps the brain go through its healing process. Okay, and lots of fluids. And the important thing is not to return to sport too quickly. So you have to be carefully monitored time-wise, especially for my main practice is in Ireland, and there's a lot of rugby players and there's a lot of jockeys, and my goodness, do they get injuries? Amazing, yeah. So they're not allowed, obviously, you say contact sport until they're symptom free. First question, of course, is that enough time? Is that enough time to actually for the brain to properly heal? Okay. I don't think so. And I think that that's where the risks come. What I see in practice is a cumulative traumatic brain injury. And this is really important because, and there's a sport called hurling it's called in Ireland, where you have the sticks, and it's pretty violent. You know, they wear helmets, so some of them do, not all of the guys, but the sticks are high. You're trying to get the ball in the air, and you're likely to get a hurley round the head quite a lot. Okay. And these guys, and like I was treating quite a famous jockey just last week, actually. I treated quite a lot of different concussion things in my last week in practice, who'd been run over by a horse, like very severe injury, actually. You know, huge impact. So what can happen though, if you're looking at rugby players, or you're looking at other sports people in contact, sports boxers, you know, I mean, it's direct, isn't it? So they can accumulate. So you have an injury, say a direct impact injury here, you have more of a whiplash type injury, which has a slightly different effect on the system. And there are consequences that you can detect, pick up. And no, you can't, you know, which cannot be picked up because they're functional changes, as opposed to, well, they are, the thing is, they're microstructural changes which aren't picked up, right, on CT MRI, but that you can feel them. And that's where, as we come onto this, the great opportunity for this kind of work is actually we can detect, you know, so often you put your hands on, you go, what have you done to your head? You can feel a direct impact here. It's very clear. And they'll say, and interestingly enough, they go, oh, nothing. And then they'll go, oh, actually, I got a hurley around the head last week. You know, I forgot about it. Classic, you know, boys, you know, oh yeah, I did, you know, fall or whatever. But what happens is you start to build up and not recover from these multiple strain patterns. And then the micro damage accumulates. And this boy, I was helping one of my associates out last week we were treating, who he had 3 or 4 concussions. And then suddenly, bang, constant headache, constant night and day, right? His dural membrane, the whole dural globe had locked down, right? And it was the accumulation. You get to a tipping point where things just create trouble, okay? So another thing, if you're talking at more different types of brain injury. So if you've got an ischemic brain injury, which we treat a lot of with babies or in adults who've had strokes, you have the mast cells. And mast, I'm very into mast cells because I just gave a course on immune system last week. But they live inside the meninges, the coverings of the brain, right? And they are protective. So the problem actually is they live within the cerebrospinal fluid. The cerebrospinal fluid has a wonderful it actually has its own biome as well, but it has a lot of immune cells in it in the brain. And the problem with mast cells is they can be quite over responsive, and if you get quite a lot of mast cells releasing their histamine into the area, they can cause a rapid vasodilation and potential hemorrhage. Okay, and they can act. What they can act is they can act to degrade the vascular endothelium, the beautiful inner lining of the micro vessels, right, which are on the outside of the brain and certainly some way in, and that's true of more bigger brain trauma, but it's also true. Why I'm saying that is it's also true on a very micro level, okay? And some of the microvasculature is hugely important that surrounds the brain. So what is chronic traumatic encephalopathy, right? As I said, traumatic brain injuries accumulate damage, especially true if you're playing, say, rugby, and the rugby, the power in the hits in rugby these days is phenomenal. I mean, it's crazy, and obviously in boxing, the idea of being punch drunk is exactly that, soccer, even heading the ball, all of these are very important things. And it's really very much in the press now. Last year, for example, some researchers in Boston scanned 376 former NFL, American football players, and found 345 of the 376 had evidence of chronic traumatic encephalopathy. Okay, so in CTE, I'm going to call it for speed, there is a cascade of pathophysiology. So the damaged cells release glutamate, which acts to flood calcium into neurons, which creates damage. Then, as I said, the mitochondria get damaged, and then you get this neuroinflammation and apoptosis, cell death. There are particular areas of the brain which are prone. There's a lot of areas that can be prone to damage, but there's particular areas that I'll talk about specifically because I find them quite interesting. Number one is, and at the front, the prefrontal cortex, okay, that gets a lot of direct head trauma, okay, but it can also have the effects of a whiplash type concussion pattern because it's going to hit the front. The prefrontal cortex sits on the cisternae, these water beds of the brain, right? But actually that protects it. The brain is incredibly it has a wonderful protective system, which is the bathing of the whole cerebrospinal fluid, right? The whole brain is surrounded through the subarachnoid space with cerebrospinal fluid. So it's like a tadpole that's floating, okay? And it has this lovely floatiness, which makes it, what is it, about a fifth or no, maybe even less of its actual weight because the fluid system holds it in space. It's got this extremely strong, resilient dural membrane, which protects the brain as well from direct trauma. The problem with the dural membrane is often in these concussive situations is it gets locked down and you can feel it in particular areas and often even globally. The whole thing has a degree of motility, an ability to move within itself, which just gets blocked and shut down, okay? Now, what is the important thing, okay, with the prefrontal cortex is one of its executive function of the brain. For example, things like impulse control. So if you have an impulse to do something, the prefrontal cortex comes in and says, no, you're not going to get angry at Jar that's triggered me. Yeah, you're going to be, an adult and you're just going to whatever. Now, if your impulse control is damaged, it can lead to problems. You can get them in certain types of ADHDs and certain type of things in certain children, and teenagers, of course, have difficulties with that because the whole prefrontal cortex rewires itself when you're a teenager. Another subject. But so there has been links actually with these NFL players being more likely to end up in jail, more likely to become violent criminals. And they're linking it up with a tendency to violence. Okay. So how many folks, for example, in prison have chronic traumatic encephalitis? Question. So another, I'll just talk about another two areas. What covers some of the cranial bones, some of the cranial nerves, okay? I'll just talk about two. A classic one is when you have this brain whiplash, yeah, especially with the jolting forwards and backwards of the brain, what it can do is it can tear some of the olfactory nerve, the nerve that's the first cranial nerve, the nerve of sense of smell. It can tear off the filaments that pass through the cribriform plate and into the frontal, and because it goes up into the cortex, underneath the frontal cortex is where the ganglia of the olfactory nerve is, so that you lose the connection between, in that olfactory tract, you lose your sense of smell. And through that, you lose a lot of your sense of taste, because the sense of smell is important in the makeup of the sense of taste. So that I've treated that quite a lot, where people with whiplash have lost their sense of smell and taste. Another thing is what happens is when the dural membrane can get locked down, there can be quite a lot of compression between the head and the neck, okay? And it can lock up parts of the occipitomastoid suture, the tentorium, the whole dural membrane can get shut down at the back, and it can affect function of, say, the vagal nerve with all of its consequences, and it affects all the different systems. The adrenals don't have any direct vagal supply. Everything else does. I mean, and it has a whole effect on the whole vascular system. So it's a huge ramifications, and that's why often the vagus is implicated when you're sick as well. It could be the vomiting centers, but the vagus is often implicated when someone has more of a kind of chronic nausea after a concussion. Now, another one which is important, and you could mention more, but is the function of the hippocampus, okay, and some of the areas locally around that, parts of the limbic system. And this is again, this is a personal view, okay? So I'm not, it's just something that I've witnessed. So I'm just going to say it as that. This is not evidenced, except for by my sensations and people who work in this way. Is the hippocampus lies below the inferior pole of the lateral ventricle. Okay, the ventricular system of the brain is very important container of the cerebrospinal fluid. Okay, cerebrospinal fluid is very important in the process of detoxification of the brain, and it's shown increasingly some of the modern research about how the cerebrospinal fluid programs the brain is very, very interesting. Have to look that up. So there seems to be a lack of fluid fluctuation in the lateral ventricle. I mean, the lateral ventricles have these wonderful choroid processes, not processes, that produce cerebrospinal fluid, okay? So they're making cerebrospinal fluid at I think it's 50 milliliters a day, right? They're making these, and a lot of they're in the third ventricle as well. And they create this fluctuation of this movement of the cerebrospinal fluid by creating quite a lot of it, okay? And if everything's shut down in that area from traumatic brain injury, okay, it can lead you to memory processing issues, okay? And it can eventually lead to cognitive decline, which is a huge area of interest for me, clinically working with people And the functional ventricles in relationship to cognitive decline is a very, I think, potentially exciting area for this kind of work again. So what's the normal treatment for post-concussive or CTE? So there's some research that's coming out about targeting some of the pro-inflammatory enzymes and blocking them so that the kind of neuroinflammation, which is present, is minimalized, because neuroinflammation creates damage, okay? And it can be more global. You see, it can start in a local area and it becomes more of a global thing. And that in itself has an effect on the dural membrane, because actually a lot of the immune cells of the brain are created in the bones or the dura, in the cranial bones and the dura, which is an interesting thing as well. So vestibular therapy, often you're left with in a long concussive, post-concussive, long concussion with problems with dizziness and a lack of balance. It's a very common symptom. So there are specific balance exercises and gaze stabilization to strengthen the often damaged vestibular ocular reflex, okay? And that's a whole area. There are nowadays, which is very modern because it's just come in, hasn't it? I think it was in the Women's World Cup, the smart mouth guards in World Rugby, which monitors these fast acceleration decelerations and flags players that need assessment. Now, that doesn't stop them getting hit, but it may indicate that someone is coming up to a threshold of what they need. What I'm saying here is actually there is not a lot that people can do about this. I mean, this is what they've got, and it's a problem. Okay, it really is a problem. So, just one other aside from concussion, as a response to concussion or any kind of traumatic brain injury, there is the kind of physiological processes of shock with its consequent effects on the autonomic nervous system and other systems, where the system can go into overwhelm, shutdown, dissociation. And there's often a sense of disassociation. When you've had any direct or indirect traumas, there is a sense of disassociation. You get a feeling sense that their midline has gone awry, gone astray. If they've been hit from one side, say, it feels like their center is over here. And actually, when I'm teaching how to treat any kind of traumatic situation, you have to allow for their midline to return, right? Without doing that, your treatment is much less effective, okay? You have to look for, and all you do is ask the question, where's their center? And you don't force it back in, you acknowledge it, right? I used to force it back in with autistic kids. They didn't want to be in there. They were quite happy with the stars. So all you do is acknowledge it as a practitioner. Where is this person? Why is this person beside themselves? Or whatever. And it's obvious in these situations. So they have to return their center. The brain, according to Sutherland, works on a specific fulcrum, okay, lamina terminalis. So the brain, when it went through its original development, everything is moving towards lamina terminalis in what we would call the inhalation phase. That fulcrum, brain fulcrum, be set astride with traumatic brain injury, etc. So let's come on to what cranial osteopaths and CST people, where they have a particular method of coming in and actually helping this. And I'm completely biased, but I think it's extremely effective. And you can't sort everything out, but I spend a lot of my time treating these effects in children, young adults, and older. And so just looking at the very simple 5 phenomena that Sutherland talked about, which was the movement of the central nervous system, okay? The fluid movement of the cranial bones, okay? And the movement of the dura. The dura has a movement which has a fulcrum of motion, the fulcrum of the motion of the dura. So all of these And then, yeah, the sacrum is the fifth. So, and the cerebrospinal fluid has the fluctuation as well. So you've got all of these fluctuating, moving parts, right? So interestingly, the research, again, is backing up some of these things that he was talking about coming up 100 years ago, okay? And talking about actually how the motion of the cerebrospinal fluid programs and could encourage the brain movement itself. Yeah, and that's why we're very interested in the fluctuation and the movement of the cerebrospinal fluid. So, for example, in someone who has a post-concussive syndrome, there can be a lack of fluctuation of the cerebrospinal fluid. The CSF isn't moving, okay? And it stops, it's just gone shocked, okay? Just by restoring this is really important because it bathes the brain, helps the brain in its detoxification, and is also really important in restoring the normal brain detoxification process at night. Okay, so there's this whole work that's come out quite recently about the lymphatic function of the brain, where the cerebrospinal fluid in the subarachnoid space, when we're in shortwave sleep, comes from the subarachnoid space in towards the third, fourth ventricles of the brain. So there's this movement inwards, and then there's this movement outwards, and it's a slow, rhythmic breathing. This is very much what we feel when we're working and when we're doing particular techniques like a CV4, for example. So part of, and when I'm working certainly with autistic children, part of it's very nice to restore this normal fluctuation of the cerebrospinal fluid. Okay. Okay. Number two, you've got dura. The dura can lock down in response to traumatic shock, right? It happens in difficult birth deliveries with babies. Yeah. You can have what we would call traumatic membranous inertia. Okay. And it can be focal, or it can be global, depending on the type and quality of the traumatic injury, which could include birth. But restoring that is really important, actually, because it seems to have a direct effect on the freedom of function of the nervous system. So looking specifically at the central nervous system, if you're working, for example, with children who have had a different kind of traumatic brain injury from an ischemic, hypoxic situation where the blood supply goes, they don't take the first breath, for example, or there is some problem with the placenta in the delivery, and they lose their blood supply, and there's this whole traumatic brain injury that it incurs. When you're working with these children after this, you're working when you're feeling the motion and the motility of the central nervous system, parts of it are not moving, right? And parts of it are damaged beyond repair, sort of beyond repair. But the areas around it feel like they're not moving. They haven't got this freedom of movement. So if we get freedom of movement back, it seems to help in the cellular metabolism and very much in the neuroplasticity, right? So the way that the brain can reconnect itself in different ways. I mean, a child's brain, certainly up to the age of 4, has a huge degree of neuroplasticity, but we still do have some as we get older. When we learn something new, we're employing neuroplasticity. We're synaptically wiring up a little bit more in a different way in certain parts of the brain, like the temporal lobe. So what we want is to get motion, okay? Motion of the CNS, which can help with its restoration of function. And if you think about how the pathophysiology of some of this CTE there is a lot of cellular, neuronal destruction, microvasculature issues, and the whole thing becomes inflamed, right? There's an inflammatory process. If you restore some of these basic functions, like the cerebrospinal fluid, the dural freedom, and the motion, with inherent motion, you can help minimize the effects of accumulative damage, basically. And And therein, I think it's terribly important in preventative care, actually, because this damage is accumulative, it's unseen, it only gets to a certain level when there become markers, certainly in the biochemistry, inflammatory, pro-inflammatory enzymes that can be picked up. And in terms of actually something you can see on a CT scan or an MRI as damage areas. So it's terribly important. The one I forgot to talk about, which is actually quite interesting, because this jockey I was treating last week, who went through this terrible fall where he was trampled by the horse, he fractured his sphenoid bone. And he he's a great guy, Irish laughing and joking. And he I brought my children to him. Sorry, the other way around. He brought his children to me. And he's like, whatever you need, just do it. We know that, you're the person to come to sort out my hair. And I say to him, this is amazing. You're so lucky, he's basically, the sphenoid bone had taken most of the forces, and severe forces, right? Fractured, which is a great thing, actually, because actually it's the easiest thing to heal. Yeah. Then actually, if you get that trauma through the central nervous system directly, it's much more traumatic for it. Okay. So actually, the bone took the strain, the bone took the force, and the bone intraosseously can heal very nicely. Yeah. And he has no post-concussive syndrome at all. Absolutely fine on that level, but I'm still treating him because I just want that fracture pattern to resolve itself, and I'm treating some stuff in his arm, whatever. But great. So actually all of these areas are quite involved. I think that's all I need to say for now. If there's any questions. I don't know how long I've been talking. Anyway.
Thanks, Ian. Brilliant. That's
Cool.
wonderful. Yes. So any question? I find this very interesting. I mean, I treat a lot of horse riders
Yes.
here west of England. We have a lot. In fact, I saw two today. And very often it feels like what you're saying, that this can persist for years.
Yeah. Oh, very much.
That kind of cumulative, and particularly around inflammation. And I'm curious, you mentioned about inflammation, and I often wonder, well, I can feel it, but I'm not exactly sure where it is. Is it in the fluids? Is it in the memory? You know what I mean? So you mentioned
Well,
something.
I mean, inflammation can be an inflammatory response can be in any tissue.
Yes.
But the whole immune cascade can function in any tissue, actually. So very much so. But also what you can have is you can have local inflammatory situations, but they can program more of a global pro-inflammatory state. And say, for example, you have say a classic example is a woman who's kind of peri or postmenopausal. Estrogen levels have dropped off, which helps to act to kind of contain an inflammatory state. And then you start actually getting these aches and pains become more and more and more, because actually the immune system is not kind of tempered in its way, and you start getting these chronic symptoms that can persist for a long period of time. The thing with horse riders, of course, is they tend to fall on their butt. So
Yeah.
actually, what I didn't mention of the five phenomenon is the sacrum is locked down, and that lower pole of the sacrum can shift its fulcrum of motion. And if it shifts its fulcrum of motion in a different way, it will have an effect on the whole tentorium and the
Yeah.
whole dural globe,
Yeah.
and lock it down. And actually, and if you don't resolve the forces that are in the sacrum, and often with nasty falls, you can get intraosseous strains of the sacrum.
Yeah.
You can't resolve the head end.
Yeah. Yeah, that's very, very common. In fact, Sarah's got a question about that. Interested, she says, interested to hear what you feel when you sense your concussion client is healed and ready to play again. Do you suggest exercises for client as well to support healing, especially if they have the pattern of density in their buttocks, sacrum, and lower back? Also keen to know how early you recommend starting gentle cranial work after an injury.
Yeah, that's an important one, because there can be a lot of inflammation, right, and immediately after an injury. But it depends on what you're doing. I suppose my answer would be as soon as you can, as soon as possible. Because the trauma patterns in there, right, on the side of the pitch. There's a a nice story of one of my colleagues. He's quite a famous osteopath. I won't mention his name, but someone had a on the rugby pitch had an acute concussion and went into seizure pattern, and he got on there and did Sutherland's resuscitation technique, which is to take everything into external rotation and hold, right? And the guy obviously came out of the seizure very quickly, so you're straight in there. That's, in an ideal world, but you have to be careful because there can be some sort of vascular weakness. And you have to be, I suppose you have, but actually what you can do is you can start at the sacrum if you feel, but you have to be aware that treating the sacrum has an effect on the other end, but if you can alleviate some of the physiological effects of shock straight away, yeah, and then you can come back to some of the detail a little bit later, so I mean, personally, but I think you have to have the experience to feel confident to treat stuff that in an acute level, an acute. But actually, a lot of the time, the people who wander into the practice are in a post-concussive situation where things have accumulated and they've got chronic symptoms or somewhat chronic symptoms. And, that's when they really need the help there, and you can get in there. As with regards to exercise, it's all, for me, it's because of these, because the dural fascial system, and this is your area, John, the dural fascial system is intimately connected. You can't really separate them. How can you physiologically, right? The actually fascial patterns affect the dura, and dural patterns they are fascia. It's all the same thing, right? Can affect each other. So anything that will allow for some kind of space and fluid return of, like Bowen technique, of the dural fascial continuum is hugely important. So yes, absolutely. But I always say stretching, please, stretching based yoga,
Yeah. You mentioned something I missed about targeting enzymes when you're talking about neuroinflammation. Can you
that's not me. That's what they're doing in the lab at the moment.
how do they do that?
So they're trying. I don't know how they do that.
Okay.
That's advanced biochemistry, and I don't know. Basically, sounds clever, but I mean,
I mean,
I suppose what they're doing is they're isolating. I think what they're doing is they're isolating enzymes which are involved in a pro-inflammatory response and looking at how to target them with medication. Yeah,
I get you.
yeah.
Get you. No, I'm asking this really because it's something I'm seeing a lot of in practice, and it's quite tricky to work with. I feel, and it creates havoc in the body. I mean, really, in all kinds of all the systems of the body.
I mean, I gave a course last weekend, no, 10 days ago, on perception in the neuroendocrine system, and just talking. I mean, it's a huge subject because inflammation actually is involved in most of what we see in clinic, most of what people see in hospital, from cancer to cardiovascular disease to, inflammation on some level is massive. It's hugely increased, I think, for a variety of kind of trigger pro-inflammatory reasons and environmental toxicity, etc.
Yeah.
So actually you could spend I'd have to spend a whole weekend talking about it. Yeah.
Great. And if there are any other questions, please put them in the chat. This thing, you mentioned it earlier about if women have a concussion at a certain point in the cycle. Could you talk more about that? I didn't quite
Yeah,
understand.
that's research. I mean, I don't know, but it's widely known that women will certainly present with more symptoms of concussion than men do, and which you would think it would be the opposite way round, because more men are out banging their heads against walls, as it were. But
Yeah.
yeah, and they're trying to put it down to possibly a change in progesterone, depending on what stage in the cycle. I think basically people don't know. I personally, I can only go from my own personal experience. In my own personal experience, I tend to treat more males with concussions personally. But
Yeah.
it's interesting. That's yeah.
Mm. And I know you do a lot of pediatric work. So you're seeing this with babies, right? So babies, for
Well,
example, who've
yes,
been
it's not. I mean, it's if you've gone through a traumatic delivery, there are a lot of forces that are involved. Okay. And so you can have direct trauma. It's not doesn't necessarily have to be violent. They've not bashed on the floor as they've come out, whatever, but they have obviously a lot of compressive forces and a lot of recoil forces
yeah,
that go through. It's the, it's the hardest thing that your head or body might have to go through in life.
yeah,
Is the birth process, and it affects all of these systems in different ways depending on the force, the direction, the force, and also the degree of potential shock that's involved. So
yeah,
actually, of course, this work is, one of the most important things is working with babies and just to release these forces, let everything come back to this nice fluid medium, which they are. But again, babies are extremely well adapted to coping with these levels of forces.
mm.
It's only
I,
when, go
I
on.
suppose you're seeing that possibly more. Well, I see it more in, for example, in babies who've been through an induction process
Yes.
where everything is faster and harder, and you know,
Absolutely, but very much so. Yeah, you have an induction, you're not fully dilated, yeah, because the guy only wants to go home, play golf, and so you're pounding the vault of the head or whatever part that presents the brow or wherever onto a contracted cervix, okay, and the force of the contractions grinding the head into that are massive. And then, of course, if you apply a ventouse, which has a strong effect on the dural membrane,
yeah.
forceps which affects the bones often a lot more. These are a lot of forces, but the baby is very well adapted. They tend to unravel most of these molding forces quite nicely. It's just when they get stuck that we have to come in and release them, which is a beautiful thing to do in my
Yeah. I
yeah.
suppose, except that things like ventouse, apart from the local force applied, is also incredibly strong tractional kind of forces.
It is. It is.
Really, the things like the suboccipital muscles, they're not really designed for that kind of thing, right?
No, and one thing, if there's any craniosacral therapists out there, which is I think is quite important, and I always mention this if you're treating kids who've had ventouse, okay, when we tend to treat towards the inhalation phase, right? You tend to get everything to open, right? Now, if you have a ventouse that's been applied often to the occiput, yeah,
Yeah.
what that does, number one, apart from what you've already said, what it does is it will shift the Sutherland fulcrum, right, which is normally at the meeting of the falx and tent, right, posteriorly, right. So what happens is if you're treating the other strains in the body and everything's going into this nice inhalation phase, flexion, right, and this fulcrum of the ventouse is still 2 inches behind where it should be, right, you're gonna make them irritable. They're the kids are going to go crazy because you're decompensating them. Yeah. And that's huge. That's very important also in children, babies who've had tongue tie releases. Yeah, you have to treat them before they get the tongue tie, the frenulonectomy, because the fulcrums of the dura are very strong. The dura is extremely strong and everything else. And actually, if they've got a fulcrum out here and you release the tongue tie, it can decompensate their whole system. And, what our local pediatrician calls, the kind of nightmare cases almost. But there's a very clear reason why.
Interesting.
So actually, yes, that's a whole subject though.
Yeah,
Yeah,
yeah, yeah. Amanda's got a question here. She works with children in rugby development. If
great.
players who have suffered repeated impact and concussions were to receive craniosacral therapy osteopathy, would it alleviate long-term damage? Well, I think the answer is
That would be, I mean, that is what I would be inferring. And what we need to do actually is to, in a perfect ideal world, we need a bunch of osteopaths or CSD people, doesn't matter, both, right? Working with a control group of kids who are high level rugby playing kids, right? And you follow them, you treat them once a month or whatever, once every 6 weeks, all the way through their childhood, and you get the other group, the non-control who aren't treated, and see what their symptomatic outcomes. That would be the perfect bit of research. But That takes a huge amount of time, money, et cetera, et cetera. But what I am inferring from this is very much so, actually, very much so. It should be, and in a perfect world, you have your physio, and you have your cranial person, right? Because it's really important, especially in impact sports, rugby, horse riding, hurling, soccer, etc. Yeah, absolutely vital, I would say. But I'm biased, but I would say that. That's an experiential thing.
I would agree with you. Absolutely, 100%. Right, I think we're nearly done, aren't we? There was a question from Jan, but I can't see it now. It's gone. Great. Cool. Any last questions for Ian before we stop? Jan's just asking, thinking of babies, could this affect breastfeeding? Yes.
The answer is, I mean, that's a massive subject. Could a difficult birth affect breastfeeding? I mean, you could give we could talk for an hour on that, because there's so many different factors involved in the lactation process, but very much so, because yes, very much so. Like, for example, it can affect the function of the pituitary, and prolactin function. It can, and obviously shock and trauma are very important in an establishment of the oxytocin bonding letdown response. And it's very important to get, in an ideal world as well. I used to teach osteopaths with an American obstetrician who was a cranial osteopath at the same time. So she would treat them as she delivered them. That's the perfect solution. Yeah. And actually, so yeah, teaching midwives this
Yeah.
is, as you're doing, is a great idea.
Yeah, yeah. I did a talk on this on Our Birth Journey, Jan, if you want to have a look at that, a whole thing about breastfeeding and this. Okay, one last question, if that's all right, Ian. Can
Yep.
being tongue-tied be a symptom of unresolved forces in the dura or other
Come what?
Can being tongue-tied be a
Ah,
symptom of unresolved forces in the dura or other symptoms that express in the throat area?
okay. I mean, there's two things here. Again, we're way off track, but when there is a tongue tie happens quite early in development, right? When the frenulum doesn't free up, so it's a fundamental developmental issue, okay, and it's possibly linked to some sort of folic acid uptake insufficiency, um, and it can link up with gastroesophageal reflux. But what happens in a tongue tie or a tongue and lip tie is that obviously the tongue is tied down in the face, so you go through the normal tongue function. Now, there can be often some of the myofascial connections of the tongue, right, that go down into the jaw, down onto the hyoid, and down across into the shoulder. Okay, all the particular kind of hyoid, mylohyoidoma, hyoid, et cetera, muscles, and fascial drags. For example, if you have a slight shoulder dystocia, and the shoulder is dragged, it can affect, okay, the omohyoid, and you can actually get you can get a drag onto the root of the tongue, right, which accentuates the feeding difficulties. So it doesn't cause it, but it can make it a lot worse. For example, if you don't have an extreme tongue tie and it's a minor posterior tongue tie, yeah, if you resolve the rest of the forces in the face and the mechanics of the face and the mechanics of the shoulders and the whole of that and the cranium, you may not need to have the tongue tie treated. You can get rid of the feeding difficulties. That's about 20 seconds on yeah.
Thanks. That's really interesting about the shoulder. And also, yeah, we've had a series with Alison Hazelbecker on tongue tie as well. She's very good on that. I don't know if you come across her work. Have you, Ian? She's a real powerhouse.
Fabulous.
Thank you so much, Ian. That was really brilliant.
Great.
And
yeah, they'll put, I think, can we put up my details on my website?
Yes.
dynamicsofstillness.com is my website. And yeah, if you've got any questions, just send me an email, right?
So dynamic
The no
Stillness.
dynamics of stillness
Dynamics
of stillness.com is the website. And I've got online courses and all sorts of stuff and where I'm teaching. And dynamics of stillness at gmail.com is the email.
Okay, perfect.
Brilliant.
And stillness at gmail.com.
Yeah.
Thanks so much, Ian. That was really brilliant.
Nice to
Excellent.
talk to you.
All right, take care. Thanks,
Bye.
everybody. Bye.